So, good evening, friends. Welcome to yet another session of Doc Tutorials. And today we'll be discussing some of the questions in oncology from the grant test that you have recently taken. So, this is a long planned discussion. You're going to have your imminent INASS examination coming up, and many of the questions will be from these questions that we have already put up in the grant test. Now, some of these questions may not come directly, but it will be from areas that come repeatedly in many of the examinations. So what we find is that, the zones are important rather than actually having the exact question itself. So you have to study the area from which the questions are coming. And once you do that, then you will get a good chance that you will be reading the areas, and from that the questions will come and then you can answer it. That is how it works in most of the INASS examinations. So welcome one and all friends again to both the YouTube session and also to the Zoom live session. So let's get on with the discussion. So the first question that we have is Sievert classification. What is it being used for? What is the use of the Sievert and Steen classification that you have? So the Sievert's classification is used for the classification of lung tumors, GE junction tumors, adrenal carcinoma, or neuroendocrine tumors. So here this is a pretty straightforward question that we have. The Sievert and Steen classification is used for the diagnosis of GE junction or OG junction. Both are essentially the same, gastroesophageal junction or the esophagogastric junction tumors. So that is what the Sievert's classification is used for. So if you look at the answer is going to be B. Most of you would have gotten this answer right in the grant test. So let's see some of the other points with regard to the Sievert classification. When Sievert published the paper way back in 2000, this was a very impactful paper which had an influence, because till that time, the management of the OG junction tumors was quite random. It depends on who is going to handle it, whether it's a thoracic surgeon or whether it's going to be a upper GI surgeon, who is going to handle the tumor and how it is handled was quite variable. Now, since the evolution of the Sievert classification, a lot has changed in the management and it has simplified the process for us. So if you look at it, this is mainly used for adenocarcinomas of the GE junction. That is the first point that you have to remember, my friends. It is used for adenocarcinomas. It is not used for squamous cell carcinomas. It is only used for adenocarcinomas. That is the important point that we have to remember first. It is used for adenocarcinomas. I will stress it again. Right. So there are three types of Sievert's classification. Three types of Sievert's grades as far as the adenocarcinoma of the OG junction is concerned. You have the type 1, 2, and 3 coming from top to bottom. So type 1 is basically something that starts as adenocarcinoma of the lower esophagus. And where is the epicenter? The classification is basically dependent on the epicenter. So if you have a lesion which is going to be here, and suppose there is a lesion which is going to be sitting here, then you look at the epicenter, meaning the midpoint of the lesion is what you look at. Now, where is the location of this midpoint? So if this midpoint is located 1 to 5 centimeters above the anatomical OG junction, that is what you call it as a type 1 adenocarcinoma or type 1 Sievert's type. In essence, this is going to be a adenocarcinoma of the lower esophagus. So let me draw this a little more clearly for you. So this is there. So you take it as 1 to 5 centimeters. So this is 5 centimeters. This is going to be your OG junction. This double line I have drawn here, the stick line I have drawn here is going to be the OG junction. You got the 5 centimeter mark here. You got the 1 centimeter mark here. So between these two lines, if the epicenter of the tumor is going to lie, that is known as a Sievert type 1 adenocarcinoma. On the other hand, if you take it as between 1 centimeter and below the anatomical junction, if you have 2 centimeters. Okay, so if it is between 1 centimeter above and 2 centimeter below the anatomical OG junction, let me try and probably color it a little bit differently. So let's assume this yellow line is the OG junction. So if you take it as 1 centimeter above and 2 centimeter below, then if you have the tumor that is arising in that area, if the center of the tumor lies in this area, that is a true carcinoma of the cardia or the OG junction. And this one lies between 1 centimeter above and 2 centimeter below the OG junction. Now, Sievert's type 3 is basically a carcinoma of the stomach where the tumor epicenter is between 2 centimeter and 5 centimeter below the OG junction. So it starts at 2 centimeter below and extends all the way for 5 centimeters. And from there, it infiltrates into the, OG junction. Now, these three types are important and the management of these three is also relevant. Now, there is some confusion between DeVita and NCCN, but remember, my friends, follow only NCCN whenever there is a discrepancy. So what we have is, how do you manage these Sievert junction, or rather the OG junction tumors, according to the Sievert classification? Now, type 1 and 2 are managed as esophageal type. Type 1 and 2 are managed like an esophageal adenocarcinoma, and type 3 is the only one which will be managed as a gastric type. Okay, so the type 3 is the only one which will be managed as a gastric type. That is a true gastric cancer with the epicenter starting 2 centimeter below and extending up to 5 centimeters below the OG junction, and it has to involve. So the next question that will come is, suppose you have a tumor like this. The tumor is sitting here. The epicenter of the tumor is here at 4 centimeters from the OG junction. So is this Sievert's type 3? No. What you have to remember is, this tumor has to creep upwards and it has to involve the OG junction. Only then you can call it as a Sievert's type. So whatever be the type of adenocarcinoma, the OG junction has to be involved for you to take up the classification of the Sievert type. So few points again I'll stress. One is, it is applied only for adenocarcinomas. It does not apply to squamous cell carcinoma. Second point is, type 1 and type 2, both of them are treated like esophageal tumors. They are not treated like gastric cancers. They are treated like esophageal cancers as far as management is concerned. And we know the distances. It is starting 1 centimeter above and below it is up to 2 centimeters. This is the Sievert's type 2. Anything above is going to be your Sievert's type 1, and anything below this 2 centimeter mark is going to be your Sievert's type 3. So these are the major points that come as far as the GE junction tumors and the Sievert's classification are asked. This is again a common question that comes repeatedly in multiple examinations. The Sievert's classification, what are the types which are there, how it is done, all this is something that comes repeatedly. So let there be no confusion as far as the management of G junction according to the Sievert classification is there. I think DeVita mentioned at one place that type 1 is treated like esophageal and 2 and 3 are classified as gastric. No, it is not true. Follow NCCN. Type 1 and type 2 are managed as esophageal types, whereas the type 3 is going to be managed like a gastric type of adenocarcinoma. So this is how it is. So type 1, type 2, and type 3. This is the three types that we have. Type 1 is the distal esophagus, type 2 is the true cardia, and type 3 is the subcardia. And the distance, as I already mentioned, is between 1 centimeter above and 2 centimeter below the anatomical OG junction. So 1 centimeter above and 2 centimeter below. Anything above 1 centimeter, if the epicenter is there, that is a type 1. And anything below 2 centimeter, if it is there, that is going to be a type 3. And in between these two lies the true zone of the cardia. And type 1 and 2 are treated as esophageal adenocarcinomas. Right. Let's go on to the next question. According to the AJCC 8th edition staging for testicular cancer, PT1A seminomas are based on which size cutoff? So actually the question is framed slightly, wrongly. All this has to be less than. It is not greater than. It should be less than. I think they gave the answer wrong, but you can have the size cutoff as 3 centimeter. The correct answer to this is 3 centimeters. Less than 3 centimeters is going to be your PT1A, and anything which is greater than or equal to 3 centimeters. Now remember, my friends, lot of places you will get this less than, greater than, and equal to. That is very, very important. For example, for thyroid cancers, recently we know that the age cutoff has been changed. As far as thyroid cancers are concerned, the cutoff currently is less than 55 years, which means it is up to 55 years. Okay, 55 is not included. Greater than or equal to 55, if the age is there, then you have stage 1 to 4. If it is less than 55, meaning up to 54 years of age, you will have stage 1 and stage 2 only as far as differentiated thyroid cancer is concerned. The same way here in testicular cancer, PT1A. What do you mean by PT1A is basically a tumor confined to the testis, and the size cutoff that you have is less than 3 centimeters. It is not 3. If it is 3 centimeters, you know, if the size of the tumor is 3 centimeters, then it becomes a PT1B tumor. It is not a PT1A tumor, then it becomes a PT1B tumor. Right. So if you look at the actual ACCC classification, again, I'm stressing it is greater than or equal to 3 centimeters. That becomes your PT1B tumor. Okay. So PT1B is going to be greater than or equal to 3 centimeters. Anything which is less than 3 is going to be your PT1A. Okay. So smaller than 3 centimeters or larger. Okay. Then this is again a favorite question with the examiners. All of us know that T4 is very clear that, whenever you have scrotal invasion, that is T4. What about T2 and T3? The size cutoff you have already gotten less than 3 and greater than or equal to 3 and confined to the testis, including the reti testis. So that is one question that will keep coming repeatedly. Reti testis invasion is going to be only the whatever stage it is going to be. It doesn't matter. It doesn't change the stage. It is still going to be only T1. So next thing that we have is lymphovascular invasion. So when we have a lymphovascular invasion, even if the tumor is limited to the testis, it becomes a T2 tumor. The same way when it is going on to the epididymis or it goes on to the tunica albuginea. So epididymis and tunica albuginea become your T2 tumors. So what is T3? T3 is going to be cord. So this cord involvement is again and again asked as a question in multiple examinations. So cord invasion becomes a T3 tumor with or without lymphovascular invasion. Now this LVSI is something that is coming up in a big way, and also extranodal extension. In multiple tumors, this LVSI and your extranodal extension come into play. So in this, you remember, as far as testicular tumors are concerned, lymphovascular invasion makes it a T2 tumor. Cord invasion makes it a T3 tumor. So when you have invasion of the tunica albuginea or the epididymis, it still remains a T2 tumor, and reti testis does not change the state. So these are some points that you need to remember. So T1 is basically confined to the testis. Reti testis invasion does not change the stage. Here we have the size cutoff, less than 3 and 3 centimeters and more. Then you have lymphovascular invasion. If there is lymphovascular invasion, it becomes T2. The same way, the next structure which is going to be there is going to be the epididymis. So if the epididymis is going to be involved, or if the tunica is going to be involved, so you remember, your anatomy. So you will have the testis and the epididymis, and then you will have the cord going up like this. So anything that remains within the testis, it becomes a T1 tumor. And here you will have the tunica albuginea and the tunica vaginalis, which is going to be there. So when you have the tumor which is extending on to this surface, then it becomes a T2 tumor. Becoming here becomes a T2 tumor. Cord becomes a T3 tumor. So you try to remember it pictorially. That will make things better for you. So this one is T1. When it is going to be nearer structures like either the tunica albuginea or your cord structure, or your epididymis, then it becomes a T2 tumor. And other than this, you remember that LVSI. Okay, LVSI is a criteria that will again make it a T2 tumor for you. So LVSI, then you have spread to the epididymis and spread to the tunica. All these three will come under T2. T1 is going to be anything confined to the testis, and T3 we know is involvement of the spermatic cord, and T4 all of us will know this for sure, and that is generally not asked as a question in the examination. I hope that makes things clear for you as far as that particular staging is going to be concerned. Right. So which of the following is considered to be a good prognostic factor in colorectal cancer? So in any cancer, generally we have various pathological factors which will come into play, and these may be grouped as either good prognostic or it may be bad prognostic. So the factors which are mentioned here are mucin production, MSI status high, MSI status low, and CRM involvement. So in this, the obvious answer to this question is going to be your MSI high. The answer to this question is MSI high. Now, when we take up factors that are involved in aggressive behavior, all of us know this high-grade tumors, poor differentiation, mucin production. Mucin production, many of us may not know, but mucinous tumors generally have a tendency to kind of recur. They may be oozing on, and the extent of invasion cannot be identified. And they will also have a tendency to form peritoneal metastasis. So, peritoneal metastasis are going to be very common as far as the mucinous carcinomas are going to be concerned. And the same way, signet ring cell carcinomas, when we have a signet ring cell carcinoma, that is again something that will have a high extent of peritoneal disease and distant metastasis and generally a poorer prognosis. And as I already said, any lymphovascular space invasion, venous invasion, lymphatic invasion or perineal invasion, whenever we have these features, all this makes it an aggressive tumor. These are kind of like common to all pathologies. Any tumor you take, whenever the tumor is high grade, poorly differentiated, having mucin production, except in breast. The only exception to this one is going to be probably your breast carcinomas. So whenever you have a mucinous breast carcinoma or the colloid type of breast carcinoma, as we call it, the breast cancer with the mucinous type is going to be a very, very good prognostic tumor. Almost zero chance of distant metastasis is going to be there. And 99%, or 95%, they have a cure rate as far as mucinous breast carcinomas are concerned. But anything in the GIT, whenever there is mucin production, remember, it correlates with an aggressive behavior. Now, one special factor as far as colorectal cancers is concerned, and nowadays being extended to other gastrointestinal malignancies also, is going to be the presence of circumferential resection margin or the circumferential radial margin. So for this, you have to understand that suppose this is going to be the lumen of the tumor. Sorry, this is going to be the lumen of the bowel, and this is going to be the wall of the bowel, what I have put up in red color. And suppose you have a tumor which is going to be there, and here it is going on. And let's have the circumferential margin of the tumor is going to be here. Okay, so this green zone, what I was on, is actually the circumferential resection margin. Now, the circumferential resection margin should be at least 1 millimeter to be called as circumferential margin is free. So this is a golden number, my friends. Remember this. So circumferential resection margin should be at least 1 millimeter to be called as a free margin as far as rectal tumors are concerned. And this is what was found by, or rather what was used by Heald. The principle of TME was there much before, but Heald was the first person to use sharp dissection, and he coined the term TME or total mesorectal excision for excision, especially in the posterior aspect of the rectum. He defined that there is something called as an MRF or the mesorectal fascia. Okay, so he used the term mesorectal fascia or MRF, mesorectal fascia or MRF, and this one should be at least 1 millimeter. The margin, what you're considering is the radial distance. Remember, it is not the horizontal distance, it's the radial or the depth kind of distance that you're looking at. And this distance should be at least 1 millimeter to be calling it as a clear TME or a complete TME when you will call it, or a clear margin when you will call it, is the margin should be at least 1 millimeter. So involvement of the circumferential resection margins is one of the highest negative prognostic factors as far as rectal cancer is concerned. It is associated with a very high degree of local resection, local relapse, and also with presence of distant metastasis. Right. So there are some other high-risk features which are also present. We all know that, when you have colorectal cancers, the staging is T1 and 2 will come under stage 1. And then you have your stage 2, which is going to be your T3 and T4. Now, in this, T1 and T2 usually do not require any other therapy. Stage 1 stage 1 colon cancers do not require any other therapy. On the other hand, T3 and T4 also, that is stage 2 tumors also, do not require any other adjuvant therapy except when some of the factors are present. And some of the factors which are very important here, which are considered to have a very aggressive behavior, this one includes presence of obstruction, presence of tumor perforation, adherence to local organs, even though there is no extension to the surrounding organs. So there is a difference between adherence and actual involvement. So if you look at the margin will still be clear. But if the tumor is coming close here and it is adherent without being involved, then you call it as tumor adherent. So the presence of tumor obstruction, tumor perforation, presence of tumor adherence, then you have presence of mucin production, high-grade tumors, poor tumor differentiation, LVSI. So all these are factors that make us think that this patient should go in for adjuvant chemotherapy, even though the patient may have only a stage 2 disease. So stage 2 disease also requiring chemotherapy is going to be there in presence of these high-risk features. And in this, One of the factors which is a good risk feature is the MSI high status. Now we have a panel of 5 markers. They are called as the Bethesda markers. Okay, so there are a panel of 5 Bethesda markers which will be tested. Usual mechanism of testing for MSI status is going to be by something called as IHC or immunohistochemistry. So usual method of testing for MSI or microsatellite instability is going to be by IHC. Now there will be a panel of 5 Bethesda markers. If 2 or more markers are found to be mutated, that is going to be called as a MSI high status. If one of the markers is having a mutation, it is called as MSI low. It is called as MSI low. And if all the markers are normal without mutation, it is called as MSS or microsatellite stable. Now, the presence of MSI high histology with at least 2 markers which are going to be mutated is considered to be a good risk feature. And in these patients, generally chemotherapy is not required. A study in this case is actually recently the evolution of this drug called as dostarlimab. This is a little kind of offshoot. I sometimes kind of include other factors. Dostarlimab also came as a question in the last aims. What is the use of dostarlimab? What is it used for? So dostarlimab is one of the recent monoclonal antibodies which is used as an immunotherapy agent. Okay, so it is one of the latest immunotherapy agents. So in immunotherapy, if you consider dostarlimab, where is it used in rectal cancer? It is predominantly in the MSI high cases. The advantage, or rather the startling thing that we had with dostarlimab was there was a study where 14 patients were studied using dostarlimab, no other therapy. The plan was to use dostarlimab and assess the response. If they had a poor response, they will go for the standard chemotherapy and radiation arm. If they had a good response, then they will go for observation. So this was done for rectal cancer as a trial. It came last year. So in rectal cancer, what it was found that all 14 patients had a 100% PCR. So what do you mean by PCR? PCR stands for pathological complete response. So 100%, meaning all the 14 patients responded completely to this particular drug called as dostarlimab, and none of them needed to go back and have either radiation or surgery. Now, if you take up rectal cancers, the mainstay of management, as all of us know, is going to be neoadjuvant chemoradiation or neoadjuvant radiation. And now total neoadjuvant therapy is coming in. And after a period of around 8 weeks, we will go in and operate and then continue to give adjuvant chemotherapy. This is the standard of care, meaning radiation and surgery are going to be the mainstay of management as far as rectal cancer is concerned. But if you take it with MSI high tumors, that constitutes only about 20% of all colorectal cancers, they have a high degree of response to dostarlimab, and in general, they have a very good prognosis. And this may definitely come as a question. This is coming up something as a big way with the use of immunotherapy in current days. Right. Next question is going on to FAP, which is the true statement, or which are the true statements. It is defined clinically the presence of more than 100 colorectal adenomas inherited in an autosomal dominant fashion. Epidermoid cysts can occur, especially in Gardner syndrome, and all the above are true. I think most of you would have gotten the answers right. This is known, very clearly known factor. All the factors are true here. FAP is familial adenomatous polyposis, where you have more than, the diagnosis is established by the presence of more than 100 colorectal adenomas. It is predominantly a clinical diagnosis. You need to identify the mutation, but clinically you put your finger inside and rectal sparing, unless it is there, which happens in about 10% of patients. All other patients, they will have a clear carpeting, or completely the surface will be covered by adenomas. Multiple polyps will be there. That is why it is known as the familial adenomatous polyposis. So multiple adenomatous polyps will be there, scattered throughout the colon. In many cases, it will be more than 1,000 polyps will be there, but the minimum number will be at least 100 polyps. If you have a scattering of more than 100 polyps throughout the colon and rectum, then that is enough to make the diagnosis of familial adenomatous polyposis. You will find that in almost 80% of cases, it is a positive family history will be there, but in about 10 to 15% of cases, you will find that it arises because of new mutations. So what is a mutation? The mutation happens in the APC gene. So APC gene is found in the long arm of chromosome 5. So these are some common questions which will be asked. So chromosome 5. So 5q is the mutation where you will happen. The inheritance is by an autosomal dominant fashion. The inheritance is by an autosomal dominant fashion. It is equally likely in both men and women. The lifetime risk is 100%. Very important. So any patient who has an FAP gene mutation, APC gene mutation, these patients will definitely go on to develop colorectal cancer in their life. The common age group is somewhere around 20 to 25 years of age. So 20 to 25 years of age is when the patients will start developing or rather will go on to develop the malignancies. The screening will start at 10 years. Colonoscopy screening, the recommended age is around 9 to 10 years. You will start the screening for colonoscopy in patients with known, a family history of FAP. So in such patients, such an early colonoscopy screening is needed. And if they have the mutation, then they will definitely have to go a prophylactic, ileal pouch anal anastomosis after doing a total proctocolectomy. Now, other than the, colorectal adenomas that we have, they have multiple other tumors. The common polyps that we get are one is the gastric polyps, and then you will have the duodenal polyps. Now, in the duodenum, it is something similar to what we get in the rectum. You will have the adenomatous polyposis that develop in the duodenum. So, in the duodenum, the cancers are possible. So, periampullary carcinomas, periampullary carcinomas are going to be very common because of the duodenal adenomatous polyposis. And these are the second most common cause of death. So, the second most common cause of death is supposedly your duodenal periampullary carcinoma that develops in the adenomatous polyps in the duodenum. Now, gastric region, you will have fundic gland polyps, you will have scattered polyps occurring throughout the stomach, but these do not become malignant. So, the risk of malignancy in the stomach is very, very low as far as the FAP is concerned. On the other hand, duodenum easily turns malignant, and it is considered to be the second most common cause of death in patients with familial adenomatous polyposis. The first most common part of that is going to be your colorectal cancer. Second is going to be your duodenal adenocarcinoma, especially in the periampullary region. And the third one is what is known as your desmoid tumors. So desmoid tumors are going to be very, very common as far as, they are the third most common cause of death. Okay. Now, there is some discrepancy between which is the second and which is the third. Sabiston gives one in one chapter and the other in another chapter. But from what I could see in many of the textbooks, the second most important cause of death is usually marked only as duodenal adenocarcinoma. So that is what I will go with as far as an answer is asked in the MCQs. The third most important cause is going to be desmoid tumors. Now, desmoid tumors, all of us know, usually start off as scar sites desmoids. And we know that both intra-abdominal and extra-abdominal desmoids, both of these can happen in patients with familial adenomatous polyposis. In patients without the FAP diagnosis, usually it will be extra-abdominal desmoids. But in the patients with FAP, the intra-abdominal desmoids are going to be very, very common. And usually they develop at the site of the previous colectomy. Now, Gardner's syndrome is one where you will have, epidermoid cyst and bony tumors. All this can happen. You've got the Turcot syndrome, you've got the Gardner's syndrome. Turcots will also have the neural manifestations. So like this, many variations of FAP are there. One other variant is known as the AFAP, attenuated FAP, where the number of polyps will be usually less than 100. So instead of having the 100 colorectal adenomas, they will have less than 100 colorectal adenomas. All this depends on which location of the APC gene is going to be involved. So based on that, the variation in the presentation can be there, and there is the phenotypical variation can be there based on the genotypical level of mutation. So attenuated FAP is one area where you will have a less than 100 colorectal adenomas, and these patients generally do not always need to undergo a prophylactic colectomy. We can wait and watch depending on the extent of the disease. And rectum can definitely be spared in these patients if they have an attenuated FAP. The questions that are commonly asked are, which is the gene which is mutated, which is the APG, the long arm of the chromosome 5, which is the most common cause of death, the second most common cause of death, the desmoids related to that, the questions can come. So these are some common questions that keep happening as far as your adenomas, as your FAP is going to be concerned. Right. All the following statements regarding the Plummer-Vinson syndrome are true except, so which is the false statement here. Also called as the Patterson-Brown-Kelly syndrome, increases the risk of esophageal adenocarcinoma associated with iron deficiency anemia, glossitis, cheilitis, brittle finger nails, nutritional deficiencies, and chronic mucosal irritation with retained food particles at the level of the webs contributes to the pathogenesis of these neoplasms. So this is again a sitter you can easily make out the answer to this question. But sometimes in our exams we miss the simple questions. So this is one such example of that. I believe a percentage of people mask this wrong. The answer is, of course, which is the false statement, is esophageal adenocarcinoma. We all know that Patterson-Brown-Kelly syndrome or your Plummer-Vinson syndrome is associated with esophageal and hypopharyngeal squamous cell carcinomas. It is not adenocarcinoma, it is squamous cell carcinoma. So here, all the features which are mentioned here are present, like iron deficiency anemia, glossitis, cheilitis, brittle fingernails, splenomegaly, and esophageal webs. One question that is asked is usually the development of your carcinoma is going to be proximal to the web. This is the answer which is given in Bailey. So the question is it proximal? Is it distal? Is it at the web? Usually the answer is proximal to the web, because it is clearly mentioned in Bailey that the cancers, the squamous cell carcinomas usually develop proximal to the web. It can be understood as well. So suppose you have got a esophageal web here, sitting here, and you've got a stasis of food substances here. So the irritation is going to be basically in this particular area. The stasis is going to be in this particular area. And that is the reason why we have all the development of malignancy proximal to the web. That is going to be more likely. And what is the percentage who develop? It is about 10% of patients with Plummer-Vinson syndrome or Patterson-Brown-Kelly syndrome who will develop hypopharyngeal or esophageal epidermoid carcinomas. The mechanism, multiple reasons are shown. One is because it could be due to the iron deficiency itself, micronutrient deficiencies, and again, as a direct result of irritation from the retained food particles. All these are theoretical mechanisms that are put forward. No one knows the real reason, but all these could be important in the pathogenesis of these lesions. Right. Next, going on to head and neck, the type of neck dissection. This is a particular favorite of mine. So supraomohyoid neck dissection is a type of neck dissection for N0 of the oral cavity. What level of lymph nodes are removed in SOHND? Is it level 1 to 5, 1 to 3, 1 to 4, or 2 to 4? So this is again a common question. The neck dissection or the neck node levels, again and again they are asked. So this is just based on the triangles of the neck. So level 1 is here. Actually, this is slightly marked wrongly. It should be from here to here. Okay, and posterior to this is where you will have the level 2. You can see the digastric, the anterior belly of digastric, the posterior belly of digastric, and you have the jawline of the mandible. These three together form the level 1B of the neck, or the submandibular triangle. Then you have the anterior belly of digastric, the opposite side anterior belly, and you have the hyoid bone. So these three together will form the 1A level of nodes. So 1A and 1B together are the submental and the submandibular triangles. Then you have the level 2, 3, and 4, which are based on the jugular level of lymph nodes. So the jugular level of lymph nodes are based on, one is from the skull base. The landmarks which you have to remember are skull base. Then you have the hyoid level. Then you have the cricoid level. Then you have the clavicle. So from skull base till the level of the hyoid, that is going to be level 2. Remember, my friends, all of this is based on your anatomy. Bony landmarks are supposed to be provided. So when you take it, you have the level from the skull base up to the level here, which is corresponding to the level of the hyoid bone. This is going to be level 2. From hyoid till the level of the cricoid is going to be your level 3, lower border of cricoid, to be more specific. From the level of lower border of cricoid up to the level of the clavicle is going to be your level 4. So the supraclavicular will usually come under the level 4. The supraclavicular nodes will usually come under the level 4. And remember, my friends, the posterior border corresponds to the posterior border of the sternomastoid. So whatever is posterior to the posterior border of the sternomastoid, that is what is called as the level 5 nodes. And level 6 is going to be the central compartment nodes. In level 6 also, you have got a right and the left levels. So remember, it can be a unilateral or a bilateral neck dissection as far as level 6 is going to be concerned. Now, what are the types of selective neck dissections, or what are the types of neck dissections in general? The gross classification of neck dissection is going to be as comprehensive and selective. So what do you mean by comprehensive neck dissection? Comprehensive is something where level 1 to 5, all the neck node stations are going to be removed. From level 1 to level 5, all the neck node levels, if they are removed, that is known as a comprehensive neck node dissection. If any of the levels are left behind, then it is known as the selective lymph node dissection, selective neck node dissection. So what are the levels that are available, or what are the types of selective neck node dissection which are there? So here we have the supraomohyoid, which corresponds to level 1, 2, and 3. Then you have the lateral neck dissection, which as we saw is the jugular node dissection, which is level 2, 3, and 4. Then you have the posterolateral, which is nothing but a combination of the lateral and the posterior type, which is going to be level 2, 3, 4, which is the lateral, plus level 5, which is going to be the posterior. Then you have the anterior, or what is known as the central neck dissection. The common term which is going to be used for this is going to be your central neck dissection. So the central neck dissection is something which you will be removing bilateral level 6 nodes. So supraomohyoid, lateral, posterolateral, and anterior or central neck dissection, which is going to be level 6. There is also a term which is known as the extended supraomohyoid. So extended SOHND, where other than level 1, 2, and 3 will also remove level 4. So level 1, 2, 3, and 4 together is known as the extended supraomohyoid neck dissection. This is the one which will be done for tongue cancers. So whenever we have a tongue malignancy, which is going to be there we'll be planning for dissection of level 1, 2, 3, and 4 together, because there is a risk of something called as skip metastasis. There is going to be a risk of something called as skip metastasis to level 4. And that is why whenever we have a tongue primary, you have to go for extended supraomohyoid neck dissection from level 1 to level 4, rather than stopping with only a level 1, 2, and 3. Right. So the next question is going to be on resectable recurrent giant cell tumor. So whenever you have going on to bony sarcomas from head and neck, so you have a resectable tumor, but a recurrent giant cell tumor following a resection done 2 years back. So these kind of clinical scenarios are again very common in today's world. You get multiple questions that are based on the clinical scenarios that happen time and again. So this is going to be a question on GCT. So you got a GCT of the bone, which was already operated 2 years back. And now the patient has got a resectable but recurrent giant cell tumor. What is the most feasible line of management? Right. So here, the options which were given, I have slightly modified the option which was given in the examination actually. So, one option was surgery followed by denosumab, but I believe the answer to this question should be actually surgery. Okay. So in general, what you have to remember is anywhere, wherever you got a resectable recurrence, the option is always going to go for surgery. Whenever the resection is possible, you go for redo surgery and remove the tumor. Now, the acceptable second alternative option will be denosumab followed by surgery. Now, if you look at it in NCCN, what they have given is if there is a local recurrence following on follow-up of the patient, if it is resectable, consider chest imaging and then consider denosumab prior to surgery. This is what is given in the NCCN guidelines, and that is the reason for the confusion. But if you look at it in the discussion part, what they have mentioned is whenever there is a recurrent disease, either local or metastatic, should be managed as per the primary treatment for localized disease or metastatic at presentation. So, in a sense, whenever you have got a resectable recurrence, always the management should be like the primary. So, if you take up the primary GCT, the treatment is always going to be primarily surgery. Whenever you have got a resectable primary, you go for surgery, and only if it is non-resectable. See, again in the discussion, resectable with unacceptable morbidity or unresectable. So these are the lesions that denosumab or serial embolization are going to be the preferred options here. And again, RT may be used as another option. So whenever patients have an unresectable disease or when there is an unacceptable morbidity, that is where you will use the option of denosumab followed by surgery. On the other hand, if it is going to be resectable, always the option is going to be surgery, and then you can go on for giving denosumab plus or minus. Even here, the denosumab is not the standard option. That was the option which was given in the, in the exam actually. But I changed the option because surgery is going to be the main treatment option. Generally, denosumab is not used for prevention. What is done is, in case it is unresectable or borderline resectable or high morbidity will be there, in such cases, you will go for denosumab and then you will follow it up by surgery. Denosumab as a question has come many times. Denosumab is a favorite with the examiners. Multiple times the questions have come again and again. So denosumab is a monoclonal antibody against the rankle ligand. Okay, so the rankle ligand is going to be there. So the rank ligand anti-monoclonal antibody is going to be your denosumab. So this denosumab is something which is going to be used in your unresectable GCT. For GCT, which is unresectable, the primary management is going to be by denosumab. Now, there are trials which are addressing in patients who have got, borderline resectable lesions and where it is resectable also, but with high morbidity, people are considering using denosumab to stabilize the disease. The problem is here, even here, it is completely mentioned here. So what happens is the risk of local recurrence is increased when denosumab is used prior to curettage. So this is an important point right there. It is mentioned. So whenever you use denosumab before you do the actual definitive surgery, the local recurrence risk is going to be increased. It is going to be almost double or 3 times when you use resection as as the second modality after giving denosumab. What should be done is first surgery should be done, and only then, if it is unresectable, only then you should consider going in for denosumab. Right. Going on to another bony tumor here, which is the most common site of skeletal osteosarcoma, which is going to be the most common site of skeletal osteoma. So what we have is in skeletal osteosarcomas, the sites which are going to be there, all of us know that the distal femur and the proximal tibia are the most common sites, that the periarticular region around the knee, that is going to be the site which is going to be very commonly involved as far as the bony tumors are going to be concerned. Now, in this, the most common site of a primary bony sarcoma is going to be your osteosarcoma. The most common primary bony sarcoma is going to be your osteosarcoma, and the most common location is going to be the distal femur, and the most common tumor is going to be your distal femur. The second most common site is going to be your proximal tibia. The second most common site is going to be your proximal tibia. So osteosarcomas are more common in the appendicular skeleton. Distal femur is 32%. Proximal tibia is going to be 15%. So proximal tibia is going to be 15%. So that is how the management of the location, or what you can call as the most common location, is going to be in the distal femur. On the other hand, if you take up chondrosarcomas, the most common ones are going to be in the pelvis or in the sacrum. So if you take up chondrosarcomas, if you take up osteosarcoma, it is going to be in the distal femur, whereas your chondrosarcomas, pelvic chondrosarcomas are going to be very, very common. Pelvic chondrosarcomas are going to be very, very common. And this is the one which is going to be important as far as the diagnosis is concerned. Right. As far as any bony tumor is concerned, the location of the tumor is important. And always, in all other sites, whenever we do a biopsy, only looking at the slides itself will be enough. But for bony sarcomas, always it is a correlation with imaging the site of the tumor. That is how it is done. Because what happens is, in a patient who has got a chondrosarcoma, let's say a chondroid tumor of the finger and a chondroid tumor of the pelvis, histologically they may appear exactly the same. On this instance, the chondroid tumor of the finger may be even put up as a chondroblastoma or a benign chondroid tumor. On the other hand, in the pelvis, if the same thing happens, it will be labeled as a chondrosarcoma. So the location, the size, all of this will matter as far as the diagnosis is going to be concerned. And that is how it works. Okay. So for bony tumors, especially for chondrosarcomas and in other tumors, we have to remember that the location is going to be very, very important. Right. Now, going on to Amsterdam criteria and Bethesda criteria in the management of Lynch syndrome. So, which is the false statement here? So, 3 or more family members with histologically proven HNPCC related cancers, one is a first degree relative of the other 2, which is not a criteria here. 2 successive generations are affected. Colorectal cancer diagnosed before the age of 60 years, and FAP is excluded. So, which is the one which is going to be important here? So here the answer is quite obvious. What we have here is the diagnosis of this one should be before the age of 50 years. Now, Amsterdam criteria and Bethesda criteria, they all came in at the time when it was based on predominantly clinical criteria, and we didn't have anything like we didn't have genetic testing, we didn't have anything like that available, or it was very long time. The turnaround time for genetic testing, when only Sanger sequencing was being used, was almost like 1 year to 2 years was the time for getting the reports of genetic testing. So what happens is, we used to use only the clinical criteria in the previous days. So if you look at it, the clinical criteria which were used are, one is that it is going to be your age of diagnosis should be less than 50 years. Then FAP should be always excluded. And then 2 successive generation and 3 or more related family members. So 3 to 1 is the rule that I remember. So 3 family members, 1 is going to be a first degree relative and 2 successive generation. So 1 is a first degree relative, 2 successive generation, and 3 or more family members. So this is the 1, 2, 3 rule that I remember as far as Amsterdam criteria are going to be concerned. And again, other than this, we should also remember that the diagnosis should be made at least in 1 person before the age of 60. And the same way, FAP should always be ruled out. Otherwise, we cannot make the diagnosis. FAP should always be ruled out as far as this one is concerned. Right. Now, if you take up the revised Bethesda guideline, so what is Amsterdam criteria used for? Amsterdam criteria is going to be used for clinical diagnosis. Bethesda criteria is going to be used for MSI testing. Currently, when should you do MSI testing for tumors? To define that is what you're using the Bethesda tumors. So diagnosis of CRC again before the age of 50 years. Again, synchronous or metachronous CRC or other HNBCC. So the expansion of Bethesda, comparison of Bethesda and Amsterdam. Amsterdam criteria use only colorectal cancers, whereas your Bethesda criteria will use both colorectal cancers and the related cancers. So what are the related cancers that you have? You have colorectal cancers, you have endometrium, which is the second most common cancer which is involved. Then it can be stomach, ovary, pancreas, ureteric tract, uterine tract, ureteric tract or the, upper ureteric tract cancers, ureter, renal pelvis, then hepatobiliary, biliary tract, small intestine. Other than the sebaceous gland carcinomas, brain carcinomas, and keratoconiomas, all these are considered to be your, spectrum. They are all considered to be in the same spectrum as your this one. Okay, so all of this can be a part of your HNPCC, and in this we have to use both the Amsterdam criteria and the Bethesda criteria. Remember, Bethesda criteria is going to be used for MSI testing, whereas your Amsterdam criteria will be used for the clinical diagnosis. Again, to stress the 1, 2, 3 rule, 1 should be a first degree relative of the other 2. 2 successive generations are going to be involved, and 3 family members are affected. Again, 1 should be a first degree relative of the other 2. And mainly, you have to exclude FAP. Only then we can make the diagnosis very clear. So these are the things that will, kind of establish the diagnosis of HNBCC, and clinically in Amsterdam criteria, and Bethesda is to use for the checking of this one. Right. Going on to von Hippel-Lindau disease. So von Hippel-Lindau disease, which is the false statement. So it is autosomal recessive associated with clear cell histology. VHL gene is in chromosome 17q, and VHL proto-oncogene. VHL gene is actually a proto-oncogene. So these are some of the things that we are having here. So which of the thing is true? Now, the question here is, have you read the question first? So what do we have here? The question is mentioned as false except. Okay, so the question is mentioned as false except. So what it essentially means, a double negative makes it a positive. So what you're looking for here is actually a true statement. What you're looking for here is a true statement. So if you look at the only true statement, forget all of it, all the rest is going to be false. So which is the only true statement in this? All of us know that VHL is going to be associated with your clear cell histology, renal carcinoma. So clear cell renal carcinomas are going to be present as far as your VHL is going to be concerned. So all the other statements are false. So it is an autosomal recessive? No, it is an autosomal dominant condition. It is present on the chromosome 3. 3p25 is the one which is the correct answer. And it is an oncogene. It is a tumor suppressor gene. It is not an oncogene. So if you look at it, von Hippel-Lindau disease, it is deletion or mutation or methylation of the VHL gene. So VHL gene is present in the 3p25 locus. And here what you get is highly vascular tumors. So all of us know that ultimately it is the HIF1 alpha that is going to be influenced by this von Hippel-Lindau disease gene. So HIF1 alpha inhibition is going to be lost because VHL gene is actually a tumor suppressor gene, and this will suppress the HIF1 alpha. Now, when VHL is going to be mutated, you will have the suppression which is removed, something similar to what we have in APC and WNT beta catenin pathway. The same way here, when the VHL gene is mutated, the action on HAF1 alpha is lost, and this leads to the development of the highly vascular tumors. So where do these tumors develop? Usually they develop in the kidney, which is the most common location of the tumors. But other than this, they also develop in the retina and in the CNS, plus pancreas and adrenal. So all these areas can actually have a very vascular, highly vascular tumor. So the most common mutation that you get is going to be your, deletion function or function deletion or loss of function mutation. So here you will have multifocal, bilateral, cystic, usually cystic and solid. It is going to be a mixed cystic and solid renal cell carcinoma. And here, what is the type which will develop? It is going to be a clear cell RCC. The type that develops is going to be your clear cell renal carcinoma. The type that develops is going to be your clear cell renal carcinoma. Now, the management of these tumors is going to be pretty complex. The reason is because normally when we have a big tumor which is sitting in the kidney, we can knock off the kidney. More often than not, the other kidney is going to be enough to take the function of this. But we have to remember that these patients will go on to develop bilateral or multiple tumors. And that is why surveillance, active surveillance is something which is an accepted treatment option as far as your von Hippel-Lindau disease is going to be concerned. So in a patient who has got bilateral tumors, if the smaller tumors are there, the size cutoff is again 3 centimeters. As we discussed in the first MCQ, we have the PT1A in testis. So the size cutoff is less than 3 centimeters. So, when you make this kind of correlations, it is a little easy for you to remember. So PT1A in testis is less than 3 centimeters. The same way, when you have a tumor which is less than 3 centimeter, you can opt for a wait and watch approach in von Hippel-Lindau disease. You can watch for a wait and watch approach. But when a cystic tumor or anything which is going to be there, which is more than 3 centimeters, then the management will be by a partial nephrectomy. Here, the role of radical nephrectomy is going to be very, very unusual. What we do is a tumor shelling out or a partial nephrectomy. Minimal margins are enough, even just enough to get a clearance. There is nothing called 1 centimeter, 2 centimeter, nothing like that is needed for a partial nephrectomy. So whenever we are doing a partial nephrectomy, it is just resecting the tumor. And what you are essentially doing is resetting the biological clock, meaning the tumor is there, you remove the tumor, you set back the biological clock. Because all these patients will eventually go on to develop a renal cancer somewhere, which is not going to be resectable or it will be resectable only with a transplant. That kind of thing is going to be there. So that is the reason why we need to be careful. We need to do only a partial nephrectomy as far as possible. And again, one other reason why these tumors respond very well to tyrosine kinase inhibitors is because of the vascularity of the lesion. The HAF1 alpha, which is going to be hyperfunctioning in these tumors, the same thing makes it highly, sensitive to, sunitinib, sorafenib, and currently to PDL1 and your PD1 inhibitors, which are all forms of immunotherapy. So currently you are using immunotherapy a lot. You are, all the kind of immunotherapy markers all the kind of immunotherapy agents, be it atezolizumab, be it avelumab, be it your pembrolizumab, any of the zumabs, any of the immunotherapy agents, all of these are used in urothelial tumors. So whenever you have a urothelial tumors, all of these can be used in urothelial tumors. Any kind of urothelial tumor can be dealt with by immunotherapy. And the same way, RCC is also something which can be, highly respondent. And nowadays we use a lot of immunotherapy even in RCC. Right. Next question is on gastric cancer. So a 52-year-old gentleman was operated and he underwent a D2 dissection with a total gastrectomy. Final histopathology shows a PT2N1M0 tumor. What is the next step in management? Is it going to be concurrent chemoradiation, chemotherapy, observation, or any of the above can be done, which is going to be the preferred treatment option as far as the management of a gentleman post-total gastrectomy is going to be considered. So now if you take it, the answer to this is a very clear-cut answer. The option is chemotherapy. Why? Because whenever a patient undergoes an R0 resection and any node positive, or if it is a T3 or T4 tumor, or any node positive tumor is going to be there. In these patients, if a D2 lymph node dissection is done, then chemotherapy is going to be a category 1 recommendation. So chemotherapy is going to be a category 1 key recommendation. On the other hand, if it is less than D2 dissection, meaning a D2 dissection is not done, then the patient has to go for 5FU or capecitabine based chemo radiation. So that is why both the options have been given here. So when will you use chemo radiation? Chemo radiation will be used when D2 is not done. So when the patient has undergone a less than D2 dissection, if the D2 dissection has not been done for this patient, then you will have to go for a concurrent chemo radiation. This is proved based on the trial known as the intergroup trial. So the intergroup 116 trial was there. This was an American study. So the intergroup 116 trial was done, which showed that there is a benefit of giving concurrent chemo radiation in patients in US. Most of the time, the patients will only undergo a D1 or a D1 plus dissection. So they don't go for a formal D2 dissection as is common in India or in Japan. So when the patient has undergone a proper D2 dissection, so when the patient has undergone a proper D2 dissection, then the management option is only going to be chemotherapy. And in today's world, whenever we talk about gastric cancer, the primary modality of therapy is going to be NACT. The primary modality of therapy is going to be NACT, and the agent which is going to be used is usually an agent called as FLOT, which is 5FU, oxaliplatin, and paclitaxel or taxanes. So FLOT is the preferred modality of therapy, NACT, as far as most gastric cancers are concerned. Whether it is resectable or unresectable, FLOT is going to be the primary modality of treatment. NACT is the preferred modality of regimen. So a lot of questions get asked on gastric cancers. The McDonald regimen. So, the McDonald regimen is going to be a very common question. Then you will have the perioperative chemotherapy, which is a very common question, which is going to be asked. Perioperative chemotherapy. They may ask you regarding this FLOT chemotherapy as far as gastric cancers are concerned. So these are all common questions that keep getting asked repeatedly. And again, the management post a D2 dissection. So what is the surgery done? Surgery is usually a gastrectomy with a D2 dissection. Depending on the location of the tumor, either it's going to be a distal subtotal gastrectomy or it is going to be a total gastrectomy. And along with that, a D2 lymph node dissection is done. So if a proper D2 nodal dissection is done, then you need to go for only chemotherapy. On the other hand, if D2 dissection is not done, then you go for a concurrent chemo radiation. That is how the patients are managed. And today's world, the most common option that we have to deal with is patients, whoever is diagnosed with a resectable gastric cancer, provided there is no GOO, provided there is no gastric outlet obstruction and there is no bleeding. Okay, so if there is no bleeding or there is no gastric outlet obstruction, then the patient goes in for a neoadjuvant chemotherapy. If these two are present, then the patient will go in for a primary surgery. They will go in for a primary surgery as the option. So that is how the treatment will be done. So the patient will go in for primary surgery if the patient has got gastric outlet obstruction or if there is bleeding. On the other hand, if they do not have bleeding and there is no gastric outlet obstruction, then the treatment is by neoadjuvant chemotherapy and FLOT. And again, remember, when will you not give chemotherapy in gastric cancer? Suppose it is a TIS or a T1 tumor, then definitely it is going to be only surveillance. If it is a T2N0 tumor, then you have the option of surveillance and again chemoradiation and also continuation of the same. So T2N0, you can still consider going in for chemo radiation. And again, whenever you have an R1 resection, remember R0, R1 and R2, all of us should know the definitions. R0 is where it is grossly and microscopically negative. R1 is going to be a microscopically positive tumor and R2 is going to be your macroscopic residue. These are again common questions that will be asked. R0, R1 and R2, all these are going to be questions. So whenever you have an R1 resection, then it is going to be chemoradiation definitively, because radiation helps whenever there is a positive margin or there is microscopic disease which is left behind. Right. So the most common subtype of appendiceal adenocarcinoma is answer is quite simple to this one. This is a mucinous adenocarcinoma. So if you look at it, there are three main types of appendiceal adenocarcinoma. You have mucinous types, you have non-mucinous colonic type, and then you have your adenocarcinoid, which has got a mixed morphology. So if you look at it, the most common subtype, more than 50%, is going to be your mucinous carcinoma or your mucinous type of adenocarcinoma of the appendix. Now, you have to remember some terms like LAMN. Okay. Then you have your DPAM, diffuse peritoneal adenomucinosis. Then you have your low-grade appendiceal mucinous neoplasm. Then you have your high-grade appendiceal mucinous neoplasm. Now, all these are terminologies which are used in relation to appendiceal tumors. All of this is something that we must be familiar with because these are, again, favorites with examiners. Lots of questions definitely gets asked from these areas. But all of us will definitely remember that mucinous carcinomas are going to be very common as far as the management is concerned. One other question that is commonly asked is, what is the most common cause of PMP or your pseudomyxoma peritonei? The question which will be asked is, the site is from the appendix or it is from the ovary. So this one, again, be very clear, my friends. The answer is appendix. Multiple times this question has come. Whenever you have a pseudomyxoma peritonei, even though the ovary may have a tumor, always do an appendicectomy because more often than not, you will find a mucinous tumor sitting in the appendix, and this will be the site of the actual malignancy. So appendiceal mucinous carcinomas are very common, and they will lead on to development of what is known as your pseudomyxoma peritonei. So pseudomyxoma peritonei is going to be very common. And previously, these kind of pseudomyxoma peritonei, there was no possible management which was there. Currently, whenever you have a pseudomyxoma peritonei, you have a curative treatment option which is possible in the form of cytoreductive surgery and HIPEC. Cytoreductive surgery and HIPEC is the current treatment of choice as far as pseudomyxoma peritonei is going to be concerned, CRS and HIPEC. Here again, whenever it comes to HIPEC, the question that will be commonly asked is, what is the agent which is going to be used? So the agent which is used commonly in appendiceal cancers or in any of the GI tract cancers is going to be your mitomycin C. Because HIPEC is often asked question. That is why I'm digressing a little from the question here. Not really digressing, it is again related to this. So when you take up pseudomyxoma peritonei, the most common cause is going to be appendiceal. And here the presentation, the only curative option is going to be a cytoreductive surgery and then going on to HIPEC. Now, when you are doing a HIPEC, the agent which is going to be used is your mitomycin C. Currently, we do not use oxaliplatin. Oxaliplatin is very less used because previously it was being used, but after the recent Prodigy trial that came, there is a trial which is known as the Prodigy trial, the Prodigy 7 trial to be very precise. So the Prodigy 7 trial was done in colorectal cancers, and this did not show advantage because oxaliplatin was used. Since then, we are not using oxaliplatin in HIPEC. Commonly, what is going to be used is only mitomycin C in the management of appendiceal pseudomyxoma peritonei. For that matter, in any patient who has got a peritoneal metastasis from any of the GI tract, commonly used is going to be your mitomycin C. Right. This is again a common question that is asked. What are the lymph nodes around the short gastric vessels station? What are they called as? So is it 4SA, is it 4SB, 4D, or 5? Now, as I told you, my friends, this D1, D2 dissections, what are the nodes of level stations? So all these are common questions that come repeatedly, multiple times, whichever exam you take, especially in INISS, they are the favorite with the examiner. So this one, again, what I would advise is generally have a chart and, kind of type it out and have it either in your book or in your iPad, or you can pin it on to your, your bedroom. Just have a look at it every day and go through it. That is the best way to remember this, my friends, because, no matter how many times you try to memorize it, it will not come. But what you can do is you can just look at the data whenever you're going to bed. Just before that, just read through it. Don't try to even memorize it. Just look at it critically. Like spend a good, 2 to 3 minutes just reading it. Nothing else you need to do. Then it will automatically become memorized in your brains without even you realizing it. Some things, whichever you find it as difficult in terms of classification, in terms of questions that are asked commonly, just you do this and this will come to you. The answer to this question is 4SA. So the short gastric vessels are the 4SA vessels. Now we have to know the level 1 group of nodes, the level 2 group of nodes, and beyond that. So, it is sometimes mentioned as station 1, and then you have mentioned as station 2 nodes. So, or N1, N2, or D1, D2 dissection. Essentially, your D1, D2 dissections will be based on these levels of lymph nodes which are going to be removed. So, you have to remember the stomach. There is also a diagrammatic representation I actually lost that picture here. I couldn't put it up here, but just remember that there is a diagrammatic representation of these nodes, which again you can look at, and that will help you in remembering it easily. So here you have top to bottom 1 and 2. So this is going to be your right cardiac and your left cardiac. Then you have your 3, which is going to be along the lesser curve. Then you have your 4, which is going to be the nodes which are going to be there along the short gastric. The posterior short gastric vessels will come here. So that is going to be your 4SA. Then you have your left gastroepiploid. The left gastroepiploid will originate here and will come all the way to here. So this is going to be your 4SB nodes. Then you have your 4D nodes. So this will come along the right gastroepiploid. So this will be the right gastroepiploid nodes. So this is the 4SA, SB, and the 4D nodes. So these are the levels which are going to be there. Then you have your suprapyloric and your infrapyloric. So that is going to be your level 5 and your level 6, or station 5 and station 6, as it is known in the Japanese gastric cancer classification. So just remember, the level 1 to 6 nodes, whatever is going to be there, they are all going to be the perigastric nodes or the station 1 nodes. Okay, they are all going to be the perigastric nodes. Now, removal of the perigastric nodes and these stations is going to be pretty easy. Most of you just need to go a little wide, and then you will get all these perigastric nodes which are automatically going to be incorporated in the specimen. So the perigastric nodes will usually form what is known as the D1 node dissection. So what is this D2 node dissection? So that is where again the nodes are going to be concerned. Now, if you look at it, these are all along the major blood vessels. So they are all going to be along the branches of the celiac artery and its major vessels. So the 7 is a favorite of the examiners, is going to be your left gastric artery. 7 is going to be your left gastric artery. Then you remember 9. 9 is going to be your celiac artery, the root. Okay, so you have the celiac vessel which is going to start here. Then it will give off the splenic on this side. It will give off the common hepatic on this side, and then will go anteriorly as the left gastric. So you have your 7, which is going to be your left gastric artery. Then you have your 9, which is going to be your celiac artery. And on this side, what you have, this is going to be 8, which is going to be your common hepatic artery. So this is going to be your common hepatic artery. And again, A and P are anterior and posterior. So whatever is anterior is known as 8A, that is common hepatic artery. And then you have whatever is posterior, which will come under your 8 posterior. 9 is going to be the celiac. 7 is going to be your left gastric. So then you have your 10 and 11. So here you have the spleen, which is going to be there. So 10 is going to be in the splenic hilum. So whatever is here in the splenic hilum, that will be your level 10. So splenic hilum is going to be your level 10. Then you have your splenic artery. So the splenic artery will be divided as, here, proximal and distal, and that is going to be your proximal splenic and your distal splenic. So whenever you are talking about a D2 nodal dissection, for a distal gastric cancer, D2 for a distal subtotal gastrectomy, you can just remember it as 1 to 11 minus 2. So all the nodes from 1 to 11 will be taken, minus 2, and again the 12A nodes will also be taken. What is 12A? 12A is going to be along the hepatoduodenal ligament. So the liver, the hepatic artery is going to continue here. It will give off the GDA, and it is going to branch off as the hepatic artery proper, and here it will be your porta, basically your hepatoduodenal ligament and the lesser omentum, and here is going to be your porta, your portal vein, your duct and your artery, your bile duct, your hepatic artery and your portal vein is going to be there. So in the hepatoduodenal ligament, along the proper hepatic artery, anteriorly you are going to have your 12A. So along the bile duct is going to be B. So this side. So this is going to be A. This is going to be B. So this is going to be there, and behind the portal vein is P. So A is for artery, B is for bile duct, and P is for your portal vein. And the thing that has to be removed is the 12A group of nodes. Whenever you are going to do a D2 lymph node dissection, it is all the nodes from 1 to 12A. All these nodes are removed. The ones that are not removed are 10. 10 is not removed in D2 dissection for a distal gastric cancer. In same way, level 2 is also not removed. So level 2, level 10 is not removed. All the other nodes from 1 to 12A are going to be removed in a D2 dissection for a distal gastric cancer. This is a question that is asked many a time as far as the management of gastric cancers is concerned. So 1 to 12A minus 2 levels, that is going to be 2 and 10. So except these two, all the others are removed in a distal gastric cancer for a D2 lymph node dissection. Now, if you're going to do a total gastrectomy, these two are also included. It includes both level 2 and your level 10 as well. So this is again a commonly asked question. When you're doing a total gastrectomy, which groups are removed? And when you're doing a distal gastrectomy, which group are going to be removed? So for this, you just need to remember that in a distal gastrectomy, you will remove these nodes, and in a total gastrectomy, so in distal gastrectomy, it is level 1 to 12A, and the level 1 to 6, the first 6 stations are going to be counted as the station 1 nodes or the N1 nodes, and these are removed in your D1 nodal dissection, and D2 is going to be 7 to 12A, and here we're going to remove selectively, except the level 10, all the other stations will be removed. All the others beyond this, whenever it grows, all of these are generally considered to be your 3 nodes or your distant metastasis. D3 nodes are generally considered to be distant metastasis. Nowadays, of course, people are expanding it. They are going even till level 16. 16 is again a common question. 16, A1, A2, B1, B2, all these are parietic nodes. 16 level is going to be your parietic. The other question that will be asked is with regard to your 14. 14 is going to be your superior mesenteric artery and vein. Okay, so superior mesenteric artery and vein will be your 14, and posterior pancreatic. So this posterior pancreatic or station 13 is very important, especially in patients with your GB malignancies. So whenever you have your gallbladder malignancy, the importance of your pancreatic, retropancreatic nodes are, we call that. We call it as the retropancreatic nodes, not retroperitoneal, my friends. It is retropancreatic nodes here. Station 13 is very important because if these nodes are involved, there is a very high likelihood that the patient will have a distant metastasis. So these are the stations of lymph nodes which are classified according to the Japanese gastric cancer classification. Very useful. And it's just that you need to follow the anatomy, and even during your surgical practice, you can remove all these nodes very clearly. So it's already 8:55, and I am closing this session for today because there is another session following this, I believe, and we will continue this session in the next couple of classes as well. In the next couple of YouTube videos as well. Probably in the next 1 or 2 days, we will be updating it in the app as you get it, and also we'll be putting up in the chat messages. So you can follow this on YouTube and you can see it on Dr. Tutorials as well. And I hope this question discussion was useful for you. I will continue with the rest of the questions in the next session. Thank you, my friends.